replicable tools and processes for complex patients. Her background includes leading a consulting firm providing services in transformation and change management. Lauren earned her master's degree in nursing from the University of Detroit with certification as a clinical nurse leader, pain management, and hospice. She was awarded the National Clinical Nurse Leader Vanguard Award from the American Association of Colleges of Nursing in January of 2015. Lauren trained as a facilitator with Elizabeth Kubler-Ross, spent several years working in hospice, and developed the first pain and palliative care service in the region. Her special interests include the impact of trauma and loss on high-frequency healthcare access and the economic potential of stabilizing complex patients through retraining and redesigning existing resources in the healthcare system. I can't think of anyone better to talk to us today. Lauren was last here in, we think, March of 2015 to lead us through a session, and then later we had the opportunity to do some case reviews with her on the phone. So some of you know her from her work there. Lauren was asked today to do a follow-up with us in Vermont on doing a record review that will help us to understand a little bit more about the patients who are in front of us. And she's agreed to do that. So with great delight, Lauren, I'm going to turn it over to you.
Thank you so much, Miriam. It's an honor to talk with you all today. One of the things I just wanted to emphasize is, as much as there's all kinds of things in my bio, because I do that for work, the thing that I get the most joy from and spend a lot of time doing is actually directly intervening in very complex cases and bringing people together to come up with a shared plan to stabilize patients. So I'm very excited to talk with you, find out how things are going, and see what other kind of support we can provide to help you in this really important work. So if you could go to the next slide, please. So our purpose today is kind of to do a current state check-in. How are you doing? To review some of the tools that you received since the beginning of the year from a few different groups, Camden and the resources that I presented in March and the tools that you're currently using. And then to provide you some tips on how to do record review. Erin and Pat and Miriam have been really helpful in sharing what are the tools you're using now and what are the barriers you're running into with coming up with a really good analysis of the record and finding the root causes. And then we're going to practice and actually apply that to cases. I think that's where it really begins to make sense. I'm a big fan of experiential learning and applied stories and experience. So that's where we're going to be focusing today. So first, just a very fast current state check-in. I can't see who's on the phone. So I wondered if you all could just give a very fast 5-second blip on what would be most helpful to you today for me to cover when we're talking about record review for stabilizing patients.
Yep, so right now everybody's lines are muted. If a few folks want to offer up their suggestions, they're able to answer this question. If you want to just type it into the text box, and I'll be sure to unmute your line so we can get Lauren up to date on what's going on here in Vermont.
Thanks, Mandy. This is Miriam from OneCare, and so I wanted to let you know, Lauren, that in asking some of the teams who are piloting this work on improving care coordination for complex patients what they're using now as a tool to review the record, there wasn't one clear tool that was emerging as, yep, we love this, we use this. There was some people who said that their record review was done mostly on instinct, and some people were using a tool that required them to calculate the number of hospitalizations and the number of days of hospitalizations and things like that. So there seemed to be a universal need for some discussion about what are the elements of a really successful record review that can be done without a daunting amount of time in the mix? And then second, if there's one that already exists, can you walk through that with us? So from my perspective, that's kind of the ask, and I'll Josh now.
That's great. It looks like nobody's typing comments. So I think I will take that as just a core principle and move forward. And just if you're feeling uncomfortable, like we're trying to do this work, we don't have the right tool, and how do we do this without that? That is a very common principle in all spaces of innovation. So what I'm doing now is working in my whole region, but I'm also simultaneously rolling out tools and processes across our system. And one of the things that I've found in this work is if you grasp the core principles of what you're looking for, you may not have the perfect tool yet. That might be something we can develop and we'll be coming to work with you on September 29. But if you have the right principles underneath what you're looking for, you'll get to the right tool and you'll get to the information that you need for patients. So it's not a failure that you don't have a working tool yet. It's normal. So I hope that helps with some of the uncomfortableness you may be feeling. So let's go to the next slide. Let's just go over briefly the tools that you already have that you're working with to help with triage and care planning. Next slide. Erin sent me a copy of the Camden cards that you're working with, which I think are great. What the Camden cards do is help begin to teach you to think about what are some of those root cause issues that may be really important to the patient and may be really important to pay attention to in care coordination. Another tool that you were introduced to from Camden was producing an echo map. This is very helpful to embed the principle of who is all in the circle of this patient's life. And I just put an echo map of the Brady Bunch on here just as to be funny because I like to have a sense of humor when I'm going through lots of change. But echo maps are a very powerful tool to get you to practice the principle of thinking who is in the circle of care for this person, who is important in this person's life. Because that's one of the principles of building a foundation towards stabilization. So next slide, please. Another tool that's going to be distributed from your core leadership is from Humboldt. And Humboldt County is doing a similar SIM grant to what you're doing, and they're working on developing out collaborative teams across the community to intervene with patients. They worked off of a tool that came from originally Care Oregon and tried to identify what were the key domains that they were looking at. This is very similar to the root cause analysis that I taught you about in March. What we talked about in March is 4 elements of root cause, looking at medical, psychiatric, social, and system root causes. The tool from Humboldt is very similar. Medical matches up with medical health trajectory. Psychiatric matches up with self-management, mental health. Social matches up with social, and medical neighborhood kind of matches up with system. There's a very lovely sort of check the box piece that goes with this image that you could begin to use to help, again, teach yourself what should I be looking for if I'm looking for root causes in a patient population. And Mandy, I don't know if you want to pull up the medical status health trajectory domain detail page that goes with this. It's pink on the top. You might have to go down. Yeah, so pull that one up. So this is just a sample of the tool. It's another resource for you. We'll go through it more in depth on the 29th, and they're going to distribute it from leadership as something that can help you practice looking at things. But it gives you a check-the-box sort of tool to run through basically a root cause analysis of what might be happening with this patient. So let's go on to the next slide. So rather than opening the lines and taking questions about record review, I think I'm just going to continue on presenting because Miriam did a good job summarizing what your challenges are. And then we'll actually go through applying it to cases. I think that's the fastest way to learn. So our core principles that we're looking at when we're working on this is, first of all, identifying the cross-continuum team. Secondly, identifying the root causes in medical, psychiatric, social, and system, and then building a shared intervention. So next slide, please. So the first principle, when I'm doing record review, the absolute first thing I'm doing, regardless of whether I only have access to the psych case management team record or the primary care doctor office record or the hospital record, the absolute first thing I'm doing is documenting who is the cross-continuum team. This is your opportunity and your team for making change with the patient. Many of our interventions in the past have been focused around, this is our silo, so whoever else is in the pool, it's helpful but not necessary to know because we have our silo and we do our specialty or we do our office intervention, and it's not really our job to link with everyone else or worry about that. The core principle that's really, really important for you to have is the more comprehensive detail you have on who the cross-continuum team is, the more likely you're going to be able to get to a plan of stabilization for the patient because you want to be linking with the team. Patients and people overall don't want 20 more new people in their pool unless they have something really valuable to add. What they really value and what I see in our work is when we work together to bring the best of each of our disciplines and each of our services into a shared plan for the patient, then they start to get better. When we create another silo and don't link cross-continuum, that's when we don't see in our work outcomes with the patients because it's more work for the patient and it's not linked and we don't get efficiency in what we're doing. So the first step of record review is quickly perusing whatever chart you have to identify who are the cross-continuum team members. And so examples of people that you would be identifying, who's their primary care doctor? Who are their specialty doctors? Do they have a psych case manager? Do they have a social worker? Do they have a therapist? Do they have a community agency they're connected to? The tool that Camden gave you and taught you, the Echo Map, is one way to do that to help get yourself thinking in that realm. The patient themselves can help you do that, but what I find really helpful is to have done homework before I meet with the patient or the cross-continuum interprofessional team because the work is more efficient then, and I've taken care of what I can do from my discipline. The Humboldt tool also gives you a way to think through and have a check the box around identifying the cross-continuum team. So the first part of record review is quickly identifying who the team is, their phone numbers, their contacts, and their role. Next page. Next slide, please. Sorry. Then the next piece is how to efficiently do a record review so you get a comprehensive look, but it doesn't take you the rest of your life looking through every page. I would recommend for your teams identifying one person to do the preliminary record review. If you're going to follow the principle of a 10-year look back, have one person from your team do that. The reason being, if one person does that over and over, they get very, very fast at it. It doesn't mean they're the only input to that, but if you start out with a pretty well fleshed out record review to start with and you bring that to the interprofessional team, you're much more efficient in filling that out quicker and getting a broader picture than if everybody is individually trying to do that or everyone is individually trying to learn that. The second thing I would recommend is that the person that you choose on your team to be, if you choose one, decide to choose one person and have them be the primary person for that record review, I would suggest that it's a nurse. It's not often that I would say a specific discipline in relation to acting out and enacting the core principles. But what happens with the medical review, you have to have a certain background and knowledge to be able to read the medical record and triage what is important and what is not. It's very hard to teach people that who have not been trained in a medical discipline. So I've taught doctors and PAs and medical students and nurses. I've also had interns and social work and masters in public health students work with me. I can't teach them how to do the medical triage around medical information because it's too complex. The other pieces, the social work and the system issues, the system issues translate pretty much to all disciplines. They can learn core principles around that. But the medical is just very, very hard to embed that because it's a specialty knowledge about what matters and what doesn't. The other reason why that triage and educated eye is important is what you'll find when you start reviewing the record, and this is unfortunate but true, is that there's inaccuracy in the medical record. I've had patients who had an HIV, so an AIDS diagnosis that was carried forward for 5 years, and they were referred to our service, and when I did the review, it didn't make any sense to me that they had an AIDS diagnosis because when I looked in their cross-continuum team, they didn't have the right providers, they weren't on the right meds. This made no sense. So I investigated back, and what I found out is the person actually had HPV. Someone had written it incorrectly as HIV, and then it had been copied forward in the record for 5 years. That affected that person's treatment and access to different services because there's different decisions about what meds you put someone on or what treatments you give them with that diagnosis. So it's made me very aware that I'm reviewing the medical record and pulling out key information, but it might not be the last word on what's happening. So starting out with the ability to triage medically is important. So effective record review, in addition to having a person identified who I would suggest is someone with a medical background, the next piece is to start with the right record. So depending on where you work and what you have access to, I always start with the most comprehensive medical record I have access to. So for some of you, that might be the primary care physician's office. Some it might be the hospital record. And some of you might not have access to either of those and are looking at a site case management agency or a community mental health agency record. I always start with the most comprehensive record, and it's a review by exclusion, essentially. So you work through the information you're looking for, and once you have a complete picture, you can stop looking. So when I start with that record, what I am doing is in the 4 quadrants, looking for the key information and filling that in until it's complete. So that I don't read every single history and physical in the medical record, and every single lab, and every single test, and every single social work note, and every single case management note. I'm looking for key information, and once that's complete, then I don't need to read every other note after that. Another way to use another principle for effective record review is if you have the opportunity to know the people that are writing in the medical record. For example, I've worked in almost every hospital in my region. I know a lot of the specialists and the doctors. And I know with physicians who writes a very comprehensive history and physical. Who writes the best ones that I can trust, that there's a lot of information. I will start with that one because I know that person's already done quite a bit of work around reviewing the record. And if I start there, then by exclusion, I won't have to read every other one that kind of has some of the information or as part of it. It's the same with social work notes and case management notes and spiritual care notes and consultants. I'm always starting with who do I know that writes the best note, and then filling it in from there. So that's a few tips about the start of the record review. I'm going to stop for a second and see if there's any questions about that. Sounds like not. So I'm going to move on to the next slide. Can you change the slide, Mandy? So the first quadrant, so some tips on reviewing for medical root causes. What I'm looking for is what are the medical things that are contributing to this person's instability? If I was a physician writing a history and physical, it would be my job to write down every single medical diagnosis that the person had and comment on their medical condition. So that would be my job writing a history and physical. This isn't a medical history and physical. This is a root cause identification. So I am looking for what are the medical diagnoses that are contributing to instability for this patient. So for example, somebody might have CHF and COPD and diabetes and gout, and they might have a history of nosebleeds, and they might have hypertension, and they might have joint pain, and they might have broken their arm. They can have multiple medical diagnoses, and it can be really overwhelming when you think, wow, I'm doing a 10-year review, I have to read everything. You really don't. What you're looking for is what are the things that are contributing to the instability medically for the patient. So I'm starting with that really, really great consult first, or that really great history and physical from someone I know who's really good at it, and then by exclusion reading backwards from there until I have a complete picture of what medical issues are contributing to the instability for this patient. The tool from Humboldt gives you some check-the-box questions you can ask to help teach yourself that more. When I come on the 29th, what we may design in is a targeted session to teach you how to do that on an efficient and deeper level. But those will give you some things to practice with for right now. Let's go to the next slide. Reviewing for psych root causes. This is the same thing. When I'm looking at what is a person's psychiatric diagnosis, but what happens is while in the medical record, unfortunately in the psychiatric record and in psychiatric diagnoses identified in the medical record, many times they're wrong. When I look back 10 years, I'm quickly gathering what are the actual psych diagnoses the person has, because that drives treatment and access to services and all kinds of things. But what was shocking to me when I started doing this for hundreds and hundreds of patients is that the same patient can have 6 or 7 different psych diagnoses, and it's very difficult to tell which one is real. And then you start to see how people end up being put on the wrong medicines or not having the right access to treatment, because if you look through the record, you'll see that inaccuracy carry forward. And you'll also see people who are not from the psychiatric specialty applying psychiatric diagnoses. So an ER doctor will write in the record, this person is bipolar schizoaffective. That's a very big diagnosis. But then I'll look through the record and find out a psychiatrist saw them and did not give them that diagnosis. In fact, counteracted that diagnosis. But the diagnosis from the ER got copied forward. over and over in the medical record. So it's important to look by exclusion. You're looking again for what is the strongest psychiatric opinion that's available to me in this record that's most likely to be accurate, and then working backwards from there. In addition, there's risk things that are important to pay attention to. So does this person have a history of suicidality? Who are they connected to in the psychiatric realm? And again, that Humboldt tool gives you a check-the-box sort of thing that you can run through, but it's the principle. If you have the principle of what you're looking for, regardless of what tool you're using, you'll be able to find it. So it's looking for what are the core things in the psychiatric realm contributing to instability, and what other resources are connected to now related to that. Let's go to the next quadrant, social root causes. So in this realm, we're looking at what are the social things that may be contributing to their instability. And here again, I'm looking for who is the interprofessional discipline that's likely put in the best notes related to this, and reading backwards from there. So by exclusion, looking for where's the most information about the core things in their social realm, including housing and transportation and access to food and trauma history and all the things that we know and are starting to learn in this field of complex care that significantly contributes to instability. I think this arena is almost first to attend to. If I think about myself as a person, when I go to the doctor, if there's something really hard going on in my life, but the doctor wants to provide teaching to me about how to decrease my blood pressure, I'm really not going to be that interested in an education program or medicines. What is going to touch my heart and help me link to health quicker is if he sees the grief from what I'm experiencing in my life and the stress, and attends to that first. The tools that Camden uses, like the Camden cards and those pieces, and also you'll find that in the Humboldt tool. They all give you some resources to start thinking about and speaking with the patients as well about what's important to them, but also to look in the record and see what might be in there that the patient hasn't brought up to you yet, but might be helpful to keep in the back of your mind as an interprofessional team to make sure you address and bring forward from your discipline. Let's go to the next slide. In system root causes, this is very important and often isn't included in tools that you'll see out there right now. I think Humboldt did a good job of identifying some of those things in a check-the-box sort of format. But in record review, what I'm looking for in system root causes is quickly reviewing what's been their pattern of access either to ER, the hospital, or primary care, and with what complaints. So what's going on there? What might be breaking down in our system? So I told you a couple of situations where an incorrect diagnosis was carried forward and then changed the entire course of how that patient was treated. You might see a situation where the patient's discharged with scripts, and then they go home and they don't have the money to get the prescription, and then they come back in the emergency room because nobody thought about they can't really afford the medicine that was prescribed for their COPD, or they didn't make it to dialysis because they don't have a car, and then they went to the ER because they were in renal failure. So nobody thinks about the transportation. Or you might see, wow, this person has been saying over and over again that they have joint pain, and everyone's treating their COPD and their heart disease, but nobody's treating their pain. And I can see that when I look back in the record. So you're trying to identify where's the system breaking down, because in addition to helping the patient and in those root cause areas, it's just as important, I think, to work on the system breakdowns. I work with equally as many patients who are completely uninterested in care coordination as I do with people who want care coordination. We have people calling us up now from the community saying, we heard you're doing this thing and we want you to make a plan for us and get our providers to work together. So our patients and families are referring themselves, but simultaneously I get reports about who's been coming to the ER and who's been admitted a lot, and we proactively work on them. And what we do is change the system. We have a lot of opportunity to improve our delivery. Now, you working in the community may not have the same opportunity to change the system itself, but you can identify breakdown in the system to start to look at how can you address that from the scope of influence that you have. So let's stop for a minute. Any questions about that?
I think we're going to try something and unmute everybody's line so they can talk freely if we have any questions. No.
I can't remember what's up to the
It doesn't look like it's going to let us do that, so continue to type in questions to the box if you have any. No questions yet, Lauren. Looks like you're just doing a great job.
Hey, Lauren, this is Miriam. Can I check out an assumption and ask you to reflect on it? Lauren's muted also. Hi, Mandy, can you hear me?
Yes. Yes, we can hear you. It looks like Lauren got muted, and we're trying to figure it out.
And Lauren, are you unmuted now? Lauren's muted.
Now go to the bring out. It's presenter. Yeah. Oh, no. So what were you going to say? Go up to the audio and click on the next down there. What's that do? Is there any way we can have Lauren call back in? It looks like something happened where we're not able to unmute her. Pin not entered. She didn't enter her audio pin for some reason. She was speaking before. Can she enter her audio pin now? I did send it to her.
Hey, this is Miriam. Obviously, we're having some technical difficulties, and I hope you can bear with us. I'm going to use this time to check out a couple things. One is, Mandy, can we try to call Lauren back in?
That's what we're trying to do, Miriam.
That's great.
Yep, we are on it.
All right, and I'm going to...
Technology is so fun. Can you hear me?
Yes. You are
Okay, can everybody?
Hey, Lauren, this is Miriam. The connection's not great, but we can hear you.
Okay. And everybody else can hear me, so I just keep going, or
I want to stop and check one thing out before you keep going. I think what you're trying to lead us through is the idea of looking at social support, medical diagnoses, psychiatric diagnoses, systems issues, to find patterns that would contribute to this patient's instability. And I think if I had to sum it up, you're saying one person getting good at it will make the process faster, and there are tools on the market to go through those domains to make life easier. Is that more or less right?
yes. And it's not to say that one discipline is the only person that contributes. So once that review is done, then you can bring it to the interprofessional team to say what other things would people add, and then also to the patient, because what the patient thinks is important, it is really a very important driver for this whole process under stabilization. And Camden's work is very good around that. Those cards are intended to get you thinking around that. But if you have both cost analysis and professional input, you have a very powerful system for stabilization.
So I'm going to stop you here again and say that I think our teams from across the state are trying to understand how to identify a system for identifying patients who might be at high risk, how to do a medical record review on them, how to bring in the patient's perspective and what their goals are, and how to, at the end of the day, how this will help to build a shared care plan.
It's a lot at once, isn't it?
So, Lauren, there's a bunch of people who are still having a hard time hearing you. We're going to put folks on mute, and we're going to try one more thing. So we're having technical assistance with the call. I apologize. Unfortunately, the audio pins are not working. So at this point in time, we're going to go ahead and end the call and ask folks to join us on September 29th. We apologize for the technological issues and look forward to seeing you at a later date.